It is a bit past noon, so I'm going to go ahead and get us started here. I'd like to welcome everybody to this special edition of the Fairbanks Ethics Lecture Series. My name is Jane Hartsock. I'm the Director of Organizational and Clinical Ethics, and it is really my absolute privilege to welcome you all here today. This is a two-part lecture series that is a special edition of our usual lecture series that we're offering in collaboration with the IUPUI Medical Humanities and Health Studies program. The Fairbanks Ethics Lecture Series is usually offered the first Wednesday of the month from September through May and covers a variety of ethical topics in healthcare. This lecture is a bit different than our typical lecture series. We do plan to try to offer this on an annual basis, bringing education and insights to current issues that affect our community through a summer intensive of sorts. But as to this particular lecture, it's important to say that racism in healthcare is not really a current event. It's a perpetual one. Although racism and the failures of post-Civil War Reconstruction have dominated the national headlines over the past several weeks, the issues confronting minoritized populations within our community are not new. They are simply more visible now and to a broader audience, largely because of the ease of filming and photographing and publishing photos, mostly to social media from our phones. The Fairbanks Center for Medical Ethics and the IU Health Department of Clinical and Organizational Ethics take seriously our responsibility to work towards racial justice in our community, but particularly as it relates to healthcare. We recognize that inequalities in health outcomes are driven by the structural racist elements of our society. And so while this webinar provides 2 hours of context, thought, and discussion, it is our intention to engage deeply in this work daily. It is in that spirit that we are excited to have Dr. Nelson here with us to help us deepen our understanding and deepen the resulting conversation. I want to offer just a few preliminaries before we continue. We appreciate your understanding with any technical issues that may develop during this webinar. Technology rarely works perfectly, and this is our first attempt at a webinar, so we'll see how this goes. The webinar is being recorded and will be available on our website, fairbankscenter.org, within the next week. You will receive a link to the eval for CE tomorrow at the email address you used when you registered for the webinar. You must complete this evaluation to receive continuing education credits. The QA box is available to post questions, and we will mediate those questions at the end of Dr. Nelson's presentation. However, we won't be responding to questions during the presentation. And the chat box has been disabled. Dr. Nelson has no relevant financial conflicts of interest. And now I get the privilege of introducing my colleague and friend. Elizabeth Nelson is an assistant professor of medical humanities and health studies in the School of Liberal Arts at IUPUI. She earned a PhD in history at Indiana University Bloomington in 2015 and served as the director of public programs at the Indiana Medical History Museum from 2014 to 2017. Dr. Nelson's historical research focuses on rehabilitative institutions such as mental hospitals and prisons. The central theme her research explores is how people carve out and hold meaningful lives in the most inhospitable spaces. She's currently working on a collaborative book project on the final years and closure of Indiana's Central State Hospital, inspired by newsletters published by patients with intellectual disabilities in the late 1980s. Nelson also coordinates the Indiana Women's Prison History Project, a group of currently and formerly incarcerated scholars who are researching the history of prisons for women, eugenics, and reproductive justice, and the health and well-being of incarcerated people. Since joining the Medical Humanities program in 2018, Dr. Nelson has offered courses on the history of medicine, disability studies, and the history of mental health care. She is developing a new course for fall, cross-listed between medical humanities and Africana studies, called Survive, Breathe, Thrive, Black Health and the Humanities. This course will focus on how Black Americans since the 19th century have advanced science, community, and holistic approaches to health in the face of medical and political systems that were designed to exclude them. With that, I will turn it over to Dr. Nelson for her presentation. Thank you.
Great. Thank you, Jane, and thank you to the Fairbanks Center for Medical Ethics for inviting me to do this. And to the attendees, I see there's a bunch of folks on the Zoom, which is exciting. I'm sorry we can't do this in person, but it is exciting to have folks potentially from all over present on this call. And I especially appreciate you taking the time to join us today. I think we're all feeling very stressed and pressed for time as this eventful summer is coming to a close. I'm gonna go ahead and jump in. So you all can see my presentation, yes, we're good? Okay, so over the past several months, we've all found ourselves in the midst of a historic moment with a pandemic that is out of control in this country, an ongoing onslaught of anti-Black violence, as well as anti-racist organizing and protest happening on a massive scale. The coincidence of a health crisis and a national reckoning with racism is not coincidental. Oh, come on. Now my slides are not working. Of course, here we go. Let's try that. Okay. The Black Lives Matter slogan, "I can't breathe," has taken on metaphorical significance, evoking the ways that our society constricts what is possible for Black people. But it also becomes quite concrete when we connect dark histories of lynching by hanging to the methods of murder by cop. And now "I can't breathe" has attained even more layers of meaning when we think about the respiratory spread of this pandemic, the masks, the intubations, and the disproportionate impact of the disease on communities of color. Racial health disparities and the devaluation of Black lives are bioethical issues. But as the philosopher Keisha Ray wrote in a brief but powerful piece published just last week, and I quote, "Bioethics is stuck circling the same topics. The main culprits tend to be abortion, physician-assisted death, emerging health technology, research ethics, the patient-physician relationship, and a few other mainstay topics. Bioethics has given minimal attention to topics such as police brutality, social determinants of health that map onto racial disparities in health, provider bias, institutional racism and racial injustice, and other topics that specifically affect Black people's health." End quote. Now, I'm not a bioethicist. I'm coming at these issues from the point of view of a medical historian. And what I hope to accomplish today is to develop a sense of connection between what's happening now, similar to what Jane was saying in her introduction, to past struggles and events. Unlike what many have said, what we're going through today does have precedent. It's not unprecedented. Race has always been one of the foundational mechanisms of structuring power in this country, and one of racism's primary effects, one might say its very essence, has been to rob Black people and other so-called minority populations of the ability to survive and thrive. So this New York Times piece dropped literally yesterday as I was preparing for this. And in it, you'll find these really disturbing graphs talking about racism's hidden toll. For example, how looking at the period between 1900 and 2015, the number of Black excess deaths, so the deaths of Black people above the white mortality rate, have totaled 8.8 million as a result of racist structures and practices in this country. Moreover, when we look into the past, we find that health justice has played a key role in what has been called the long civil rights movement, the struggle for Black equality that reaches back, I would argue, to the Civil War. I'm not the only one who argues that, and continues to this day, right? Now, the seminar I'm presenting is in two parts, so today and next Wednesday at the same time. In each of the two seminars, I'm going to be focusing on an important figure from the 20th century movement for civil rights, whose work, I argue, can inspire our thinking about race and health justice today. Next week's talk will center on the life and work of activist Fannie Lou Hamer, so I hope you'll come back for that one. Today, we will be looking at the career of Dr. William Montague Cobb, a physician and physical anthropologist who, as you can clearly see from this photograph, was the epitome of mid-century glamour. Cobb was a scientist and a medical school professor whose work was propelled by a commitment to social justice. He was a man of many accomplishments, and I'll be talking more about his education, his career at Howard in a minute. But as you can quickly see here from this list, and this is just a very partial list of all the things that he did, you can see that he led many important national organizations related to healthcare, science, and the fight for Black equality, including the American Association of Physical Anthropologists, the National Medical Association, and the NAACP. Now, there's also listed here the Imhotep National Conference on Hospital Integration, and I'll be talking about that in this talk today. Now, Cobb was what you might call a Renaissance man in both the European and Harlem senses of the term. He was a watercolorist and a talented violinist who was known for playing Handel for his students in the anatomy lab. When he was in his 70s, he made his debut as an actor, portraying the great civil rights leader W.E.B. Du Bois on the stage. So we have quite a character on our hands today. So for this presentation, I'm going to be focusing on 3 aspects of Dr. Cobb's work that I think carry important lessons for us today, as they demonstrate the importance of 1, abandoning racist ideas about biological difference, 2, fighting for universal access to healthcare, and 3, being willing to enter the fray. So that is being willing to use your position and your talents, whatever they might be, to push forward for justice. Now, William Montague Cobb was born in Washington, D.C. in 1904 to a lower middle class family. And perhaps it was because his father ran a printing business for the D.C. Black community. Young Will seemed to have been surrounded by books growing up. Before he even learned how to read, he became fascinated by the illustrations of human types in a copy of Goodrich's 1868 Illustrated History of the Animal Kingdom. This was the first glimmerings of what would become his lifelong study of human biological diversity. He went on to graduate from the premier Black high school in the nation, Dunbar High, and then he pursued a BA at Amherst College, where he studied the humanities. So this was a formation that remained strong with him throughout his life. When he was teaching at Howard, he was known for incorporating literature, philosophy, sociology, and history into his anatomy classes, which often exasperated his students who just wanted to know, what was going to be on the board exam. So he was one of our people, a medical humanist avant la lettre. So at Amherst College, Cobb entered, perhaps for the first time, a nearly all-white world, which furthered his interest in understanding race. So he was one of the few Black students there. And as he says, and this is him being interviewed when he's in his 80s, I think, and he's speaking with the frankness of an older man. He says, as I got a chance to observe the white man, I realized he didn't have an exceptional amount of brains. Some Black boys were brighter than I was, not too many, but some. And I saw a lot of dumb white boys. So I thought, what is all this race stuff all about? So that's the end of the quote. So Dr. Cobb's experiences of moving between these worlds demonstrated to him that the dominant paradigm of American society and the segregation that surrounded him, and this notion of white racial superiority, all of this was to be questioned. So by the age of 25, he earned an MD degree from Howard University. Howard was one of the elite intellectual spaces available to talented and ambitious Black people at the time. And it was the site of one of 2 medical schools that were instrumental in training the vast majority of Black physicians in the early part of the 20th century. So as it says here on the slide, Between 1910 and 1947, Howard and Meharry accounted for 90% of the African-American medical school graduates. And as I teach students about the history of race in medicine, I think it's important to retrospectively shed a light on these spaces, spaces of Black scholarship, academics, and show images of Black people pursuing medicine and science in particular in the early 20th century. Here's a picture of a chemistry class at Howard very early on in the 20th century. Now, why this is particularly important from the point of view of IU School of Medicine and Indiana history is if you look at the history of race in medicine through that lens, you get a very different picture. So if you go through, for example, pictures of yearbook pictures of the students in the schools, or go over to med school and look at the class portraits of all the graduating classes, you will see very few Black students all throughout most of the 20th century, really. And so you could get the impression that Black folks weren't out here doing work in these fields. And you can also get a sense from these yearbooks, though, about what the experience of the one lonely Black student might have been like. So if you look at the student at the left, I have a kind of pop out here. So this is what was said about him in the yearbook. Lewis is our only African. He has attended strictly to studies of all 4 years and has won the respect of the class because of his brilliant mind and exemplary conduct. So Black students in these majority white schools were treated as kind of novelties. And so you can imagine what his experience might have been like. Okay, so that's just kind of an aside, but back to Dr. Cobb. So after his MD degree, he goes to pursue a PhD in physical anthropology at Case Western Reserve University School of Medicine. Now, this was an interesting and bold choice for a young Black scholar at the time because physical anthropology was just about the most racist of all the sciences. Going back to the 19th century, scientists were using anthropometric measurements, so comparing the size of skulls of people from allegedly different racial groups, for example, to prove that races are biologically distinct and that Black people were biologically inferior to white people. In such discourses, racial difference was used to explain not only differences in appearance, but also differences in intelligence, culture, temperament, and physical aptitudes. These scientists assumed that each race had distinct characteristics, and in some iterations, scientists asserted that the human races were in fact different species altogether. And you can take, for example, the work of the scientist and slave owner Josiah Nott, pictured here, who argued that Black people were an intermediate species between monkeys and humans and were uniquely suited to enslavement. Racial science was also used to explain health disparities. After the Civil War, newly freed Black people faced a health crisis, as many fell sick from smallpox, especially in the war's immediate aftermath, and then in the ensuing decades, diseases like cholera, tuberculosis, and yellow fever. Some observers even argued that Black people's bodies were unsuited for anything but slavery. And that's what explained the pervasive illness in Black communities after freedom. The problem was, of course, lack of access to proper nutrition, sanitation, healthcare, et cetera. And as Jim Downs shows in this book, pictured here, Sick from Freedom, recently freed people were the first advocates of federal healthcare via the Freedmen's Bureau, which established hospitals throughout the South at the war's end. However, many white physicians refused to treat Black patients, and the hospitals were short-lived. Into the 20th century, as Black people began migrating to the urban north, often living in crowded slums, Black communities continued to be plagued by poor health and high mortality rates. White medical authorities often framed disease as inherent to the Black race and therefore inevitable. thus giving a kind of reason or rationale for medical neglect, and also allowed them to not address the structural and environmental causes of disease. And this was called out by Black physicians at the time. For example, Dr. Rebecca Cole, who was the second Black woman MD in the United States. In 1896, she wrote that to improve the health of Black populations, quote, "We must attack the system of overcrowding in the poorer districts, that people may not be crowded together like cattle, while soulless landlords collect 50% on their investments," end quote. So at Case Western, Cobb worked with T. Wingate Todd, an anthropologist originally from England who was more progressive than many in the field of physical anthropology when it came to the scientific study of race. Todd's research focused on a collection of unclaimed human remains from around the Cleveland area, now known as the Heyman-Todd Osteological Collection. Todd encouraged his students to question the idea that race could necessarily be inferred from skeletal remains. He had a set of skulls that he called the humiliators because he would present them for a student or maybe a rival colleague and have them guess, the race of the individual. And these were skulls that appeared to belong to one racial group, but were actually another. And so the Cobb school and then Cobb himself, as we'll see, or the Todd school and then Cobb himself, did not go so far as to say that race was completely ungrounded in biological reality, that it was a social construct. They didn't go that far. But what made this school of physical anthropology unique was that it highlighted the diversity of traits within racial groups and the overlapping of traits that can be found among individuals of different groups. So instead of seeing racial groups as distinct and dissimilar and in a hierarchy, Cobb and his mentor, Todd, were attempting to blur the lines between groups and show hybridity, variation, and unity of the human race. This was very different than the work of leading physical anthropologists in the nation in the early 20th century, such as Aleš Hrdlička, I always have a hard time with his name, who was an avowed eugenicist. His work reprised some of the anthropometric studies that had been used to justify slavery in the 19th century. And his work was focused on illustrating the racial superiority of whites on the basis of supposedly inherent differences in, say, brain development and skeletal morphology. So you can see from this quotation something of Hrdlička's attitudes. So when he uses the word retarded here, he means slow to develop, right? So he says, there's no question that there are today already retarded peoples, retarded races, and there are advanced races. And the differences between them tend rather to increase than to decrease. And there is no acceptable possibility that would make the white man wait upon the Japanese or Chinaman who's only a little bit behind, or the Negro who's a long way behind. Again, this was the leading name in US physical anthropology in the 1920s when Cobb was coming up through the ranks. So as part of his PhD research, Cobb produced a study of the hundreds of human skeletal remains that comprise the Heyman-Todd collection. And these had been gathered at Case Western from 1911 to 1935. And during this, I consider it kind of ghoulish research among all these skeletons, and Cobb called the collection Catacombs of Our Contemporaries. Cobb noted the disproportionate number of Black people's bodies in the sample. So although white people were dying at 12 times the number of Black people in the city, which was to be expected, there were a lot more white people in the city than Black people, Black cadavers represented a third of the folks who died indigent in the city's hospitals and workhouses. And so they were living in the most unstable conditions. And that's how they found themselves in disproportionate numbers in this laboratory. Cobb also noted the high incidence of tuberculosis, a disease associated with poverty, as the cause of death for individuals of both races. And what I find really fascinating about this research is Cobb notes that many of the Black individuals found in the sample were among the first wave of migrants who moved from the South to the North to seek work in the cities. And that's how they ended up in Cleveland. So Cobb's analysis of these skeletal collections was infused by a complex understanding of the social and historical processes that led to individuals' premature death in Cleveland. For Cobb, the skeletons provided an enlightening insight into the social structure of American civilization. His work thus emphasized the importance of local contexts, life trajectories, and underlying social and historical structures in understanding the anatomy and pathology of human remains. In 1932, Cobb got his PhD. He was the first African-American to do so in the field of physical anthropology. And he went back to DC, where he went to work at the Smithsonian on a survey of the skeletal collections there under the direction of, guess who? This jerk, right? When Cobb was interviewed in the 1980s about his life, he remembered working with Hrdlicka, and Cobb actually seemed kind of unfazed by the man and his racist attitudes. It seemed that they managed to find a way to work together. But he did manage to get in a good dig at Hrdlicka's habit of dressing like he was out of the 19th century. So in the interview, Cobb remembered Hrdlicka with his formal collars would walk down Pennsylvania Avenue shopping where he could get the cheapest things. And I love that. So Cobb wasn't bothered by Hrdlicka in part because of the confidence he'd cultivated, and he just kind of had that confident personality, but also because he was working on his own stuff. In addition to his work at the Smithsonian, Cobb also took up a faculty position at Howard and set up his own laboratory. In the lab, Cobb and his students collected and analyzed skeletal remains and took measurements of living individuals, mostly Black, in the DC area. And modern scholars have recognized Cobb as among the first to study racial health disparities and to forward environmental understandings of poor health among African Americans using the techniques of physical anthropology. One of Cobb's most powerful scientific contributions during this era was an article called Race in Runners, which I just love this font. I can't get over it. So this was written in response to contemporary commentary about the dominance of Black American runners in national and international sprinting and long jump competitions in the 1920s and 1930s. Race in Runners appeared in 1936, the year of Jesse Owens' legendary performance at the Olympics in Nazi Germany in Berlin, in which the American track star won 4 gold medals. To some contemporaries, Owens' excellence and that of other Black runners seemed to present a robust challenge to the idea of Aryan superiority. Many press accounts at the time, moreover, suggested that African American track stars might owe their success to some physical attributes peculiar to their race. And further, and see how this gets twisted, those invested in eugenical or racist scientific discourse saw Black athletic success as evidence that Black people had greater physical strength, but the corollary being that intellectual prowess was particular to the white race. So any scientific analysis of Black athleticism in this moment was bound to be politically charged. Now, Cobb was uniquely qualified to examine these issues. He was not only a skilled anatomist, but also a champion cross-country runner. Of course he was. So he asked, did Black people have particular anatomical characteristics that could explain their excellence in sport? His methods were complex. They included taking measurements of living individuals, including Owens himself and other runners. He used the Heyman-Todd specimens as a kind of comparative database of Black and white leg, foot, and heel lengths. He interpreted X-rays. He did biomechanical assessments of the morphology and function of the leg. He incorporated brand new research on nerve fibers, as well as the personal histories and stats of individual runners. The resulting analysis is too detailed to really go into here, but I'll just give you one of his primary arguments, which hinges on the length of Jesse Owens' calves. Relative to the average measurements of Black and white people's legs found in the vast skeletal collections at Case Western, Owens' leg measurements were closer to the, quote, Caucasoid type, that is the average calf length of all the white individuals in the sample. In addition, Cobb found that a white champion, Frank Wyckoff, had legs that conformed more closely to the, quote, Negroid type, characterized by shorter calves. So in order to avoid confirmation bias in his research, he shared these measurements with another anatomist who didn't know what he was up to, who confirmed that, and this is similar to how Todd had done with his humiliator skulls. This colleague confirmed, yeah, a lot of these bodily measurements seem to indicate a white individual when in fact Jesse Owens was not. And so Cobb's research it represented an effort of using the tools of physical anthropology, but stripped of racist assumptions, to generate new data, which pointed to variation, hybridity, and the unity of the human race, rather than clear-cut divisions between or among racial groups. As for the high number of Black champions in track and field, Cobb pointed factors such as training and the will to achieve. The successes of all athletes were not due to any specific characteristics associated with race, and Cobb wrote that, quote, when the track coach arrays before his mind's eye the galaxy of stars who've done the 100 in 9.6 seconds or better, he notes no uniformity of physique, style of running, or temperament. Okay, so that's a little bit about his scientific research. I'm gonna switch gears and talk about his contributions in another arena entirely, and then hopefully not go over time. And I'll wrap it all up at the end, right? So in addition to attacking the knowledge base and racist mindset behind the racial hierarchy of Jim Crow America, Cobb also worked to ensure access to healthcare for Black Americans who were largely excluded from professionalized medicine and to medical treatment, right? So, for example, the American Medical Association, a powerful national organization for the medical profession, allowed local chapters to exclude Black doctors all the way up until the 1960s, which in turn limited Black MDs' abilities to admit patients at hospitals. Given the indifference of the AMA to the interests of Black health professionals, Black doctors founded the National Medical Association in 1895, an association that Cobb himself would lead in the 1960s, and I'll talk more about that later. I mentioned before how in the early 20th century, hospitals were segregated throughout the country, meaning that hospitals could outright refuse care to Black patients. This was an utter catastrophe with disastrous implications for Black expectant mothers, those sick with infectious disease, accident victims, you name it. So I read an interview with the renowned child psychiatrist, Dr. James Comer, who was actually from Indiana, from East Chicago. He went to IU as an undergrad, applied to a bunch of med schools, was accepted to IU School of Medicine, but ended up going to Howard instead. And so he talks about his time on the East Coast as a student, med student in the 1950s. And he's still alive, I believe. And so this is a memory, this is within the realm of living memory. While he was a med student in the late 1950s, he witnessed a 7-year-old girl who had been injured in a car accident bleed to death after being turned away from a Maryland hospital because the, quote, Negro ward was full. Comer said, quote, a little Black girl died, not because there was no medical services, but because she was Black and could not have them. Again, this was a state of affairs that was sanctioned by the American Medical Association. In 1938, Dr. Lewis Wright of Harlem Hospital said, "The AMA has demonstrated as much interest in the health of the Negro as Hitler has in the health of the Jew." Hospital segregation was not something that was confined to the South. Until the 1940s, Black people were only admitted to one of the major Indianapolis hospitals, the City Hospital, which is now Eskenazi, right? But Black doctors were not allowed to work there. So there were some failed moments of, inclusion. For example, an African-American doctor named Gibbs was offered an internship at City Hospital in 1917. But when the white interns found out about it, they staged a walkout, forcing Gibbs to resign. And that's an anecdote that came from a blog post by IUPUI's Paul Mullins in anthropology. And he just wrote this post 2 days ago. So thank you for that anecdote. Check it out if you can find it online. It's in Invisible Indianapolis. Okay, so in response to this state of affairs, there's the link. Black people found ways of establishing healthcare systems within our own communities, right? So beginning in the 1890s, you see the founding of Black hospitals in places like Chicago and Philadelphia first, and in other cities to follow. So an entire Black medical world came into being with the training of new doctors at schools like Meharry and Howard, and the building of hospitals and nurse training schools for Black patients and practitioners. So Dr. Vanessa Northington Gamble is one of the leading historians of what she calls the Black hospital movement. And she says, quote, "The creation of Black hospitals demonstrates the strength and resilience of the Black community. African Americans were not passive victims in the fact of oppression, and rather they developed mechanisms to take care of themselves," end quote. And by the way, there are Black hospitals in Indianapolis, including Lincoln Hospital and Ward's Sanitarium. Unfortunately, the buildings where these hospitals were housed are no longer there, but due to the recent efforts of historians like Norma Erickson and Leon Bates, who you can see pictured here, they have been memorialized. So if you have a chance to, if you're in Indianapolis, make sure you drive by and see these historic markers. Okay, so despite these Herculean efforts, by the mid-20th century, Black people were still severely underrepresented in the medical field. In the 1940s, Black doctors and nurses comprised just 3% of the national supply. And by the way, the number today isn't much better. I think we're at 5% now versus 13% of the total population. So you had serious underrepresentation in the medical field. During that same period, you had the stimulation of segregated facilities through the passage of the Hill-Burton Act in 1946. So this provided federal funding for the construction of nearly 10,000 new medical facilities nationwide, which was a good thing, right? So a lot of underserved areas got a hospital, but the federal government allowed for these hospitals to be segregated. And so a lot more segregated facilities were being built in this time period. Less than a decade after this, you have the 1954 Brown versus the Board of Education Supreme Court decision, which held that segregating public schools by race was unconstitutional. And 10 years after that, you have the 1964 Civil Rights Act, which bans discrimination in all public accommodations. However, hospital administrators, in most cases, argued that these decisions didn't apply to them because most hospitals were considered private entities, so they could do whatever they wanted. In 1962, a group of Black doctors and patients filed the federal suit that became known as Simpkins versus Cone against 2 North Carolina hospitals that refused to treat Black patients. The Supreme Court ruled that because the 2 hospitals received federal funding through the Hill-Burton Act, By refusing to admit Black patients, they were in violation of the 5th and the 14th Amendments. So with that, the Simpkins decision provides the legal framework for hospital desegregation, but there's no incentive, there's no enforcement, and many hospitals were slow to desegregate or just outright refused to do so. So meanwhile, Dr. Cobb is working on this issue from a different angle. Given the persistence of hospital segregation between 1957 and 1963, he hosted seven annual conferences called the Imhotep National Conferences on Hospital Integration. And these were designed to put pressure on hospital administrators to open their doors to Black patients and physicians. The name for the conferences, Imhotep, was inspired by the Egyptian demigod of medicine. But after the first year, the American Medical Association refused to send delegates. So they were holding on, the AMA was holding on to this kind of states' rights mentality, which, you know, if the AMA membership, in particular local chapters, wanted to exclude Black doctors and perpetuate segregated medicine, they had a right to, according to the AMA. Now, Dr. Cobb was frustrated by the lack of cooperation from the AMA, but he was undeterred. As you can see from this quote, he says, "For 7 years, we've invited AMA representatives to sit down with us and solve the problem. The high professional economic levels of these bodies and the altruistic religious principles according to which they are supposed to operate seem to have meant nothing. By their refusal to confer, they force action by crisis, and now events have passed beyond them. The initiative offered is no longer theirs to accept." So he found an alternative strategy for desegregating medicine, and beginning in 1963, as the new president of the National Medical Association, he enacted that plan. The plan actually goes back deeper into the past. So way back in 1946, Dr. Cobb had testified before a Senate committee in support of President Truman's bill to establish a national health insurance. And this bill was strongly opposed by the AMA, which labeled the bill socialist. So socialized medicine, right? So this was the slogan that the AMA put with its lobbying materials against the bill: keep politics out of this picture. So the idea that you shouldn't have government interfering with the doctor-patient relationship, right? Now, Cobb had argued at the time that healthcare has to be readily available to all in a successful democracy, without regard to status or pocketbook. So in the 1960s, Dr. Cobb began to see a national health insurance plan as a potential tool for hospital desegregation. And so as he takes up his presidency of the National Medical Association, he goes before Congress again in around 1963 or 64. And ultimately, these efforts played an integral role in the passage of Medicare. There it is. Which was signed into law in 1965 by President Johnson, and which is what historian David Barton Smith has called the unacknowledged gift of the civil rights movement. The introduction of Medicare and soon Medicaid represented some, the most sweeping reforms ever made to health insurance coverage in U.S. history. Not only did they ensure access to health care for some of the most vulnerable people in American society, they also provided the incentive for hospitals to desegregate, as segregated facilities were not eligible for these federal funds. So I'm going to wrap it up, I swear. Now, what does all this have to do with today? For one, I hope to have shown how intertwined the story of healthcare access and the story of racism has been in this country, and the importance of Black leaders like Dr. Cobb in working to expand healthcare access in ways that have moved us toward a more equitable system of care. I hope to have given you a historical perspective for thinking about some of the current, often racist attacks on so-called Obamacare, and how important it is for us to continue to push for universal health coverage. This would go a long way to reducing the health disparities that disproportionately affect Black and Brown Americans. but it would also benefit everyone. Universal access would. Now, Cobb's research, which attempted to blur distinctions between racial categories, is also relevant today because antiquated notions of race continue to animate medical science and practice. Now, this in itself could be a whole talk, and I could get in the weeds with it, but I won't. I'll just give you a couple resources to look at since I'm nearly out of time. But I encourage you all to check out a couple things. First is this book by Dorothy Roberts called Fatal Invention. This book demonstrates, first of all, the instability of our racial categories. So how we come to be designated as Black or white or mulatto or whatever categories are in use at the time. Those categories are socially constructed, shifting, and they also mask the complexities of ancestry. Much of the book focuses on the promises and pitfalls of genetic science. And Roberts warns against the fallacy of seeking genetic explanations for racial health disparities. So while genes do play a role in our health and should be explored, Roberts argues that it's a fallacy to assume that our genes tell us anything about race, right? Another resource I'll point out quickly, this just appeared in May. This is a report by the Institute for Healing and Justice in Medicine and the Othering and Belonging Institute out of California. It's one of the most, it is the most comprehensive and accessible guides to these issues that I've managed to find. So it's available as a PDF. Search for it, download it. It has a bunch of references and resources in the back. It's fantastic. So in this, toward the abolition of biological race in medicine report, the authors explore things like how biological racism going back to the 19th century continues to shape clinical guidelines, how clinical research often ignores structural and environmental context for understanding poor health. And ultimately, the authors convincingly show that racism, not race, is a risk factor for disease and premature death. So racism, not race, right? So to conclude, I hope that after today, you'll continue thinking about Dr. Cobb and be inspired by the 3 principles for health justice that his work embodied. One is ensuring that the production of scientific knowledge is anti-racist in its orientation. 2, ensuring that all people can get quality healthcare services. And 3, refusing to be passive in the face of inequality and inequity. Enter the fray, right? And I invite you all to come back next week for part 2, which will focus on Fannie Lou Hamer. It will take us in very different directions than we went today. We'll be talking about issues of reproductive justice, land rights, food justice as they relate to her life and work and their relevance for health justice today. So that's all I got. Thank you.
Thank you very much, Dr. Nelson. We have a few questions that have been popping up in the Q&A section, so I'm going to read them to you and then you can answer them. The first one is a question. It notes that the government often forces desegregation through means such as the Medicare bill. What were VA hospitals doing during the 50s and 60s? Were they also segregated? And you got to unmute yourself.
Okay, there we go. Yes, to my knowledge, they were there, and there was only one Black VA hospital. I'm not sure how late that goes, but beginning just after World War I, there was a VA hospital built in Tuskegee. And it was actually run by a Dr. Ward, who was from Indiana. He was the ward of Ward's Sanitarium, so he had a Black hospital in Indianapolis, and he was also, he was a soldier in World War I, a medic, and was recruited to head the Tuskegee VA hospital, which was the only VA hospital for many decades for Black veterans. I'm not sure when there were more built or if they had to wait for desegregation to have access to different hospitals. I'll refer you to the work of Leon Bates. If you Google him and Dr. Ward's name, you should come up with a piece that Leon wrote about Dr. Ward, or I can send it to you if you need it. But it's excellent new research just came out this past year, and an interesting Indianapolis connection as well.
The next question is from good friend, Dr. Schneider, Bill Schneider. He wants to know if did Dr. Cobb practice medicine much?
That's a really good question. I don't see him doing, like, I haven't run across him talking about treating patients. He seems to have been a researcher and an educator, but I haven't run across him, you know, having a practice, for example. He may have, but I haven't seen it. And but his career is vast, and I wouldn't put it past him to be able to do all of that, because he seems to have been kind of superhuman in his energy. So perhaps, but I just haven't seen it.
Next question. So based on this history, the history that you've provided, what would you say are the top 3 to 5 insights or themes that could be applied, solutions for continued inequities today?
Well, for that, I will invite you to come back next week. So the way I have this seminar set up is I hope to close next week's presentation with some, you know, like a call to action, a list of, you know, actionable items. I will say just briefly, I think we need to think, you know, if we're talking about the healthcare arena, I think we need to think beyond the clinical encounter, right? So there's a lot of important things that happen in that doctor-patient interaction, and we need to think about biases and all of that there. But we also need to think about the wider context of access to care, like I talked about today, the determinants, the environmental determinants, economic determinants of health, the wider context. And then on this political sphere, I think we also need to widen our view. Elections are important. Electoral politics is hugely important, but there are other ways that we can shape politics or be politically active. And so that's what I'll be exploring next week in more detail.
Maybe this is something you're bringing up next week as well, but can you touch on the overall trust aspect of patients receiving care once hospitals were integrated?
That's an excellent question. I don't know that I can answer it, because I don't know that I've looked into that specific question or that specific time period in this way. That's interesting. I do think that there might be interesting comparisons to, say, school desegregation, and especially when people interpret desegregation as something that's being forced upon them. And when you also have issues of longstanding all Black spaces, all Black schools, all Black hospitals that were pillars of the community, then being closed, and, you know, educators, doctors, et cetera, being displaced. There's a lot of trauma that can happen in those kinds of transitions. So I would be looking at those things, but I don't have a good answer for that particular question.
Okay, the next question is, what would be the repercussions of removing race as an identifier in medical care and medical education if we're worried about inequities in education and healthcare, making the playing field for medical education uneven?
Right. There's a wonderful series that the University of Pennsylvania put out about these issues. I would search for this. This was on some kind of occasion, kind of looking at the history of Samuel Morton, who was one of these skull collectors and measurers, because that collection is at the University of Pennsylvania. And so they invited a bunch of scholars together to talk about the legacy of scientific racism in medicine today. And these panel discussions are incredibly rich, and they're all online. And so I would refer you there. But I would say one of the takeaways that I got from exploring some of that material is that there's a difference in assuming that race is a real biological thing that has something to do with health, because it doesn't. And so if your experimental design or your clinical practice assumes that, then that's problematic. However, it is important to keep race in mind to the extent that we are tracking, continuing to track racial disparities. So the effects of racism and our social structure on the health of different groups, which is, it's a different orientation. So I'm not advocating for race to be completely like ignored, but I think that it's a matter of being very, very careful about how it's being wielded and not assuming that it can tell you things that it can't. You can't necessarily assume, for example, someone's ancestry based on their racial identification. You can't exclude, oh, well, they can't, this diagnosis wouldn't apply to them because of their racial identification, because it very well might. So being very, very careful about using race as a kind of blunt instrument or a shortcut for things that that it doesn't actually tell you any information about.
I think we have time for a couple more questions. And the one we've got here, can you speak a little bit to the Henrietta Lacks HeLa cells issue and the lack of recognition / consent in all of this?
Well, for that, again, I invite you to come back next week, because we will be talking about Henrietta Lacks. We'll be like touching on that, and we'll be delving a little bit more into medical abuse, experimentation, this question of consent in a number of contexts. So looking at the context of slavery, looking at the context of reproductive health, looking at the situation of Henrietta Lacks, where her cells were taken from her and exploited, for, there's a lot of great scientific discoveries made, but also a lot of money, and how do we think about that? I will be going more in that direction next time, so I hope that you'll be able to come back for that.
I'm going to ask just one final question, which is, I guess, my question. Can you speak just briefly a little bit as to the systems of racism in the North? I think a lot of times our national narrative is that racism was a real problem in the South, and we in the North were sort of the good guys, and that's not an accurate or true narrative. And so I'm wondering if you can speak just a little bit to that.
Absolutely. Yeah, I mean, that's why I thought it was important to, because when I was thinking about this series, I'm focusing on two figures from the South. And so it could easily, give the impression that, oh, these were problems that were happening in a particular region. And granted, the way that things were structured in the South, the kind of overt nature of segregation in the South was different. But I think that we do forget or ignore the fact that segregation was a reality, racism was a reality in the North as well. And so I think it's important to talk about the fact that, you have people alive today in Indianapolis who can remember, being treated in the, in the bottom of a church because there was no hospital beds available, or born, at home, or having surgery on a kitchen table because hospital services were not available. This is within our lifetime, and it's happening right here in Indianapolis and other places in the North. And so, and that's just, the healthcare piece of that is just one of a multitude of this kind of structural racism that, I mean, we're still there, right? And it's everywhere in this country, taking, yes, different forms regionally, but it's something that nobody should be saying, oh, it's not happening here, because most likely it is.
Well, I want to thank you very much, Dr. Nelson, for your presentation today. And I know you'll be back next week for the second half of this, and I'm looking forward to that as well. And so this concludes the webinar for today. And if you have questions, you can email the Fairbanks Center for Medical Ethics for continued conversation or specific questions regarding CE or anything else that you may have questions about. So thanks, everybody.
Thank you, everyone.